You know that feeling, right? That sudden jolt, heart pounding, vision narrows,
Oh.
pure survival mode.
Oh, yeah, absolutely. That's your sympathetic nervous system just kicking into high gear.
It's this incredible internal chemical cascade, and today, that's what we're diving into. The drugs that tap into that exact system.
We are talking adrenergic drugs. These are the tools, really, the pharmacological keys that let us stimulate or mimic that whole fight or flight response.
So that's our goal here, to really walk through the essential pharmacology of these adrenergic drugs. Chapter 19 stuff, it's often high alert medication territory, so getting the framework right is, well, it's crucial.
And maybe first we should nail down the terminology.
Good idea.
When we say adrenergic drugs, we're often talking about adrenergic agonists. Or maybe a more descriptive name is sympathomimetics.
Sympathomimetics, like they mimic the sympathetic system. Makes sense.
Exactly. They copy what your body's natural stimulants do. Those are the endogenous catecholamines, or epinephrine, and dopamine.
Okay, so before we talk about the drugs mimicking it, we need to understand the system they're, well, hijacking, right?
Precisely. So, big picture. Nervous system starts central, goes peripheral. Then you get the autonomic nervous system, the automatic stuff, breathing, heart rate.
Stuff you don't think about.
Right. And that autonomic system splits into two famous parts. Sympathetic, that's the adrenergic side, and parasympathetic, the cholinergic side.
The gas and the brakes.
That's a great way to put it. They're constantly pushing against each other. It's this check and balance thing to keep your body stable, homeostasis.
And when the sympathetic side, the adrenergic side, takes over, that's the fight or flight.
Yeah.
You get the faster heart rate, blood vessels tightening up to send blood where it's needed most, muscles getting ready.
Yep. And adrenergic drugs, they plug right into that whole process.
So how does that process normally work? What's happening at the chemical level? Like in figure 19.2 they describe.
Okay, so it starts surprisingly simple. With an amino acid, tyrosine, that gets converted through a few steps. Tyrosine to dopa, dopa becomes dopamine, and then dopamine gets turned into norepinephrine.
Okay.
And this norepinephrine, it's stored, packed away in these little bubbles, vesicles, at the nerve endings, just waiting.
Waiting for the signal.
Waiting for the nerve to fire, yeah.
Yeah.
The action potential arrives, and boom, that stored norepinephrine gets released into the synaptic cleft.
Which is that tiny space between the nerve and whatever it's acting on, right?
Yeah.
The target cell.
Exactly, the gap. And in that gap, the norepinephrine finds its matching receptors on the target cell, binds to them, and that's what causes the effect. The heart races, the muscle contracts, whatever it is.
But it can't just stay on forever.
Right. You need an off switch. And the body has, well, basically two main ways to clean up. First, you've got enzymes. Think of them as the cleanup crew.
Okay.
There's MAO, monoamine oxidase, inside the nerve ending, and COMT, catechol-orthomethyltransferase, outside the nerve ending. They just break down the norepinephrine molecules.
Got it. Enzymes chew it up. What's the second way?
Reuptake. This is often the main way, and it's faster. The nerve terminal literally sucks the norepinephrine molecules back up out of the gap, uses active transport, pulls them back inside for reuse later.
So reuse or destroy.
Pretty much. And adrenergic drugs, they mess with all of this. They might act like norepinephrine or force more out or block that, clean up the reuptake or the enzymes.
Okay, that makes sense. Which leads us right to the receptors, those docking stations you mentioned. Alpha, beta, and dopaminergic.
Those are the main families, yes. Let's start with alpha. What's the difference between alpha-1 and alpha-2?
Right, so alpha-1 receptors, they're mostly postsynaptic, meaning they're on the actual target cell, like the muscle or the gland. You stimulate alpha-1, you get the classic fight responses, blood vessels constricting, some CNS stimulation too.
Okay, action-oriented. What about alpha-2 then? They seem a bit different.
They are. Alpha-2s are usually presynaptic. They sit on the nerve ending that release the norepinephrine.
So not on the target cell.
Right. Think of them as a feedback loop, a brake. When norepinephrine binds to these alpha-2 receptors on the nerve ending it came from, it actually tells the nerve, okay, hey, enough norepinephrine out here, dial it back. It inhibits further release.
Ah, okay, so alpha-1 drives the response, alpha-2 puts the brakes on, keeps it from going overboard.
Exactly, action and moderation. Now, beta receptors, these have those handy mnemonics, right?
They do, makes it easier. Beta-1. Think one heart. You have one heart. So beta-1 receptors are primarily located in the heart.
And stimulating them does what?
It supercharges the heart. You get positive inotropic effects. That's increased force of contraction, positive chronotropic, increased heart rate, and positive dromotropic, faster conduction through the AV node. Basically makes the heart pump harder and faster. Oh, and it also triggers renin release from the kidneys.
Okay, beta-1 is heart power. What about beta-2?
Beta-2. Think two lungs.
Yeah.
Have two lungs. These receptors are found mainly in the smooth muscle of the lungs, but also other places like the uterus, GI tract, liver.
And stimulating beta-2 causes.
Relaxation, mostly. Smooth muscle relaxation. So in the lungs, that means bronchodilation, opening up the airways. That's huge for asthma. It also relaxes uterine and GI muscle and promotes glycogenolysis, releasing glucose.
So beta-1 for the heart pump, beta-2 for opening airways and relaxing other smooth muscles.
Got it.
And the last one, dopaminergic.
Yeah, these are a bit special. They only respond to dopamine. You find them in specific blood vessels: renal, mesenteric, gut, coronary heart, and cerebral brain.
And their job.
Dilation. When dopamine hits these receptors, these specific arteries dilate, which increases blood flow to those vital organs. Really important for keeping the kidneys perfused, for example.
Okay, so we have the targets, alpha-1, alpha-2, beta-1, beta-2, dopaminergic. Now, how do the drugs actually work on these, the mechanisms of action? I think the text mentions 3 main ways, like in figures 19.3, 4, and 5.
Yep, 3 main strategies drugs use. First is direct acting. Think epinephrine. It works just like the body's own norepinephrine or dopamine. It binds straight to the receptor, activates it, job done.
Simple, like a key fitting into the lock.
Exactly. Then you have indirect acting drugs. Amphetamines are a good example here. These guys don't bind to the receptor themselves. Instead, they basically force the nerve ending to release the norepinephrine it has stored up in those vesicles we talked about.
So they cause a flood of the body's own stuff.
Right. They empty the reserves. And third, you have mixed-acting drugs. Ephedrine is the classic example. It does both.
Double duty.
Yeah, it binds directly to the receptor, and it stimulates the release of stored norepinephrine. Covers both bases.
And within these mechanisms, there's the idea of selectivity, right? Not all drugs hit all receptors equally.
Oh, absolutely crucial. Some drugs are highly selective. Phenylephrine, for instance, primarily hits alpha-1 receptors. That's its main job. Others are non-selective. Like epinephrine, again, it hits alpha and beta receptors. Norepinephrine, too, hits alpha and beta-1 mostly. Selectivity determines the drug's overall effect profile.
Which is why we can use them for so many different things clinically. Let's talk uses. For breathing problems, you want beta-2 stimulation.
Right. Correct. For asthma, bronchitis, even anaphylaxis, we reach for drugs like salbutamol, formoterol. They're designed to preferentially hit those beta-2 receptors in the lungs. Result: bronchodilation. Easier breathing.
Makes sense. What about eye conditions?
For the eyes, we often use alpha-1 agonists. Phenylephrine eye drops, for example. They constrict the tiny blood vessels on the surface, which relieves that red, congested look. Or they can be used to cause mydriasis pupil dilation, which is needed for eye exams.
Okay, but the real heavy hitters, the ones that often feel the most critical, are the cardiovascular ones?
Yes.
The vasoactive drugs.
Yes. These are the pressors, the inotropes, dobutamine, dopamine, epinephrine, norepinephrine, phenylephrine, often given by 5e infusion in critical care. Definitely high alert medications.
And this is where that dose thing gets really complex, isn't it? Like
Well,
with dopamine.
Absolutely. This concept, the dose-response relationship, is everything with some of these drugs. You really have to understand it. Take dopamine, it's like 3 drugs in 1, depending on the infusion rate.
Explain that. How does the dose change the effects so drastically?
Okay. At low doses, say less than 5 micrograms per kilogram per minute, dopamine mainly hits those specific dopaminergic receptors. The result: dilation of renal and mesenteric arteries. You're trying to improve blood flow to the kidneys.
Okay, low dose, kidney focus.
Right. Turn up the rate, moderate dose, maybe 5 to 10 mics per kilo per minute. Now dopamine starts hitting beta-1 receptors more.
So heart effect kicks in.
Exactly. You get that positive inotropic effect, boosting cardiac contractility, increasing cardiac output, helpful if the heart pump is failing.
And then high doses.
Crank it up high, usually over 10, sometimes over 20 mics per kilo per minute. Now you're predominantly stimulating alpha-1 receptors.
Widespread vasoconstriction.
Massive vasoconstriction. Blood pressure goes up significantly. So you see, low dose for kidneys, medium dose for heart contractility, high dose for raising blood pressure via vasoconstriction. The dose dictates the receptor target. It's not just more effect, it's a different effect. Titration is key.
That's incredibly important to grasp. Beyond dopamine, what about other key players? Dobutamine.
Dobutamine is primarily a beta-1 selective agonist. Its main gig is boosting heart muscle contractility, that positive inotropic effect. So you use it mainly in heart failure to improve cardiac output without as much increase in heart rate or blood pressure as some other drugs.
And midodrine. That one's oral. right?
Yeah, midodrine is interesting. It's a prodrug, meaning it gets converted in the body to its active form, which is an alpha-1 stimulant, used for symptomatic orthostatic hypotension people who get dizzy and faint when they stand up because their blood pressure drops.
But there's a catch with timing, isn't there?
A big one. Because it constricts blood vessels, you absolutely must not give the last dose of the day too late, generally after 6 p.m. or even earlier, depending on bedtime. Otherwise, when the patient lies down to sleep, they can get severe supine hypertension. Dangerous.
Makes sense. Okay, so these drugs are mimicking the fight-or-flight system. The side effects must feel pretty unpleasant, like that system's stuck in overdrive.
That's exactly what they are. They're extensions of the sympathetic stimulation. So, CNS effects, headache, nervousness, feeling restless, can't sleep, tremors. Some people even feel euphoric.
And the heart.
Yeah. Cardiovascular side effects are common and potentially serious. Chest pain, high blood pressure, racing heart, tachycardia, palpitations, irregular heartbeats, or dysrhythmias.
So if things go too far, if it becomes toxic, how do you manage that, especially since many have short half-lives?
Well, first step is always stop the drug, obviously. But if the effects are severe, life-threatening, say seizures from too much CNS stimulation, we'd likely give diazepam.
And for the cardiovascular side,
Yeah.
like runaway high blood pressure.
For extreme hypertension, you need to bring it down fast. You'd use a rapid-acting sympatholytic, something that blocks the sympathetic system. Esmolol, a fast-acting beta blocker, is a common choice. It slams the brakes on quickly to prevent stroke or other complications. But yeah, because the half-lives are often short, supportive care managing breathing, heart function is also key while the drug wears off.
And interactions. What shouldn't you mix these with?
Big ones to watch out for. Mixing adrenergics with certain anesthetics or even digoxin can significantly increase the risk of cardiac dysrhythmias. That's dangerous.
Anything else major?
Yes, a really critical one. Combining adrenergic drugs with tricyclic antidepressants, TCAs, or especially MAOIs, monoamine oxidase inhibitors.
Why are MAOIs so risky?
Because MAO is one of those enzymes that breaks down norepinephrine, remember? If you inhibit MAO with an MAOI drug and then give an adrenergic drug that boosts norepinephrine levels, you can get a massive overload. Result: acute hypertensive crisis, blood pressure skyrockets, medical emergency.
Okay, noted. Very important. What about specific populations, older adults?
Yeah, you have to be extra cautious with older adults. Their bodies often just don't compensate as well. Heart function might be less efficient. Their baroreceptors, the sensors that detect blood pressure changes, might not work as well.
So they're more sensitive.
Definitely more sensitive to the effects, more likely to get hypertension, feel stressed by the drug. Plus, you have to consider any existing conditions they have, like peripheral vascular disease or heart disease. It all adds up to higher risk.
All right, let's pivot to the practical side. Nursing process. What are the absolute must-do baseline assessments before starting one of these drugs?
Well, since we're kicking the sympathetic system, you need a solid cardiovascular baseline. That means full vitals, of course, heart sounds, check all the peripheral pulses, and critically, get postural blood pressures lying, sitting, standing to see if they already have issues with position changes. Also look at skin color, temperature, capillary refill signs of how well perfused the periphery is.
And if the drug is specifically for breathing, like a bronchodilator,
Then the focus is respiratory, naturally. You need baseline respiratory rate, rhythm, depth. Listen carefully to breath, sounds, wheezes, crackles. Get a pulse oximetry reading. And if possible, baseline peak flow measurements. You need that starting point to see if the drug is working or if things are getting worse.
okay, assessment's done. Now, implementation. Those IV vasoactive drugs, dopamine, norepinephrine, you said high alert. What are the key safety rules?
Non-negotiable. They must be given via an IV infusion pump. You need precise control over that dose, especially given the dose-response issues we talked about.
And the IV site itself?
Preferably a central line, impossible. Why? Because the biggest immediate risk with peripheral IVs is extravasation.
Extravasation, that's the drug leaking out of the vein into the tissue.
Exactly. And because these drugs cause intense vasoconstriction, if they leak out, they clamp down the blood vessels in that tissue. It can lead to tissue damage, even necrosis, death of the tissue.
How would you know what's happening? And
You'd see swelling, maybe coolness, pallor, or pain around the IV site. If you suspect extravasation, stop the infusion immediately. Leave the cannula in place for a moment, though. Then the antidote is phentolamine mesylate. It's an alpha blocker. You inject it into the affected area, usually subcutaneously, following specific protocols to counteract the vasoconstriction and hopefully save the tissue.
Okay, critical safety point. You also mentioned a reason why norepinephrine might be chosen over other pressors in shock. Something about the kidneys.
Yeah, that's a nuanced but important point. While drugs like pure alpha agonists can raise blood pressure, norepinephrine, which hits alpha and beta 1, is often preferred in shock states. It increases blood pressure effectively, but seems to cause less intense vasoconstriction in the renal arteries compared to some other agents.
So it might protect kidney blood flow better while still supporting overall pressure.
That's the idea. Maintaining kidney perfusion during shock is absolutely vital for patient outcome, so it's a bit of a balancing act, and norepinephrine often hits a better balance there.
Finally, patient teaching. What do people need to know if they're taking these, especially at home?
Number 1, take it exactly as prescribed. Don't double up, don't skip doses. Stick to the schedule to minimize those CNS and cardiovascular side effects, the tremors, the racing heart, the trouble sleeping.
What about inhalers, if they use more than one?
Ah, good point. If they use, say, a bronchodilator like salbutamol and an inhaled corticosteroid, the bronchodilator always comes first
Why?
to open up the airways. Then you wait about 5 minutes, let the airways open, then use the corticosteroid so it can get deeper into the lungs where it needs to work. And always rinse the mouth out with water after using inhalers, especially corticosteroids, to prevent thrush.
And that mid-adrenaline timing again.
Reinforce that. Last dose should not be taken after 6 p.m. or within 4 hours of bedtime, whatever is specified. Take it earlier in the day when they're up and about and need the blood pressure support. Avoid that risk of lying flat with high blood pressure.
And what symptoms should make them call their provider right away?
Any chest pain, palpitations, shortness of breath that's new or worse, dizziness, blurred vision, any sign that things aren't right, don't wait. So, pulling it all together, adrenergic pharmacology, it's really about targeted action, isn't it? It's understanding which receptor subtype, alpha-1, beta-1, beta-2, dopaminergic you want to hit, and picking the drug, and sometimes the dose, that does it best to get the response you need, whether that's vasoconstriction, boosting the heart, or opening the airways.
Right. And thinking about that, the most, I guess, profound thing from this deep dive for me is that dose-dependent selectivity with drugs like dopamine. It's not just turning the volume up or down. You're literally
Yeah.
changing which instrument is playing. So the final thought for you listening, how does really internalizing that the dose is the target sometimes, how does that fundamentally shift how you'd prioritize continuous monitoring and careful, meticulous titration versus just, setting a rate and walking away? That precision feels like everything in critical care. Thank you for joining us for this deep dive on adrenergic drugs. We'll catch you on the next one.